Good afternoon and welcome everyone to our webinar on trust in data exchange in the European health data space. My name is Nienke Schutte and I am the head of unit of the European Health Information System unit at Sciensano, which is a scientific institute and the National Public Health Institute in Belgium. And together with the Austrian National Public Health Institute, Sciensano is organizing this webinar on the first day of the European Public Health Week. And co-organizers are the EUPHA sections, Public Health Monitoring and Reporting, and Digital Health. So on the 24th actually of April, the European Health Data Space Regulation got adopted. And now it's time to look at the implementation of this regulation in Europe. However, to ensure the success of the European Health Data Space, building trust in all stakeholders involved is of utmost importance. And this webinar dives into this pivotal role of trust in citizens, health professionals, patients, in health data sharing in the European Health Data Space. And we will discuss initiatives that have mapped trust and data sharing attitudes and explore strategies to foster trust while harnessing the potential of health data, the use of health data for improved health outcomes. Today, we have a very packed agenda for you. We will first kick off with two speakers that will set the scene. They will be talking about the European Health Data Space, both the primary use of health data, so for diagnosis and treatment, and the secondary use of health data, focusing on reusing this data for policy, innovation, and research. So first, I would like to call to the stage Stefan Buttigieg, who is a resident specialist in public health medicine at the Malta Ministry for Health and Active Aging. Stefan, the floor is yours.
Thank you so much, Nienke. I'll be sharing my screen now shortly to make sure that everything is coordinated. All right, so here we are today, and as you can see, we are actually living this European health data space, and we're living what we're showing here. And I wanted to share with you a bit on how we can really communicate the value of the European health data space for primary use. My background really and truly is focused very much on being the national contact point on EHEalth at the Information Management Unit at the Ministry for Health. So I'm literally breathing, primary use on a daily basis. But I also happen to be the Communication Task Force lead for the EHEalth Member States Expert Group. Very recently, we even had a meeting in Vienna at GUB. Just a bit of a background, apart from my work, I'm also lecturing at the University of Malta, and I'm the Vice President of the EUPHA Digital Health section, which is one of the reasons why I'm here today as well. And you'll find me online, mostly on LinkedIn or Instagram. Now, if we had to take a look a bit at the state of affairs or the state of play when it comes to the number of operations, so to speak, national contact points of EHEalth, we see quite a lovely covered map with yellow and blue colors. But the colors that actually are in operations are the ones in yellow. So there's still a lot of work to be done. But as you can see now, because of the European Health Data Space Regulation, we'll most probably see a very nicely fully colored yellow, even including countries like Norway, for example, which are also going into routine operations with the patient summary service as well. So hopefully they will be part of the picture as well. But keeping that in mind, this is constantly evolving, and I come here today talking to you a bit more about the electronic cross-border health services. And in fact, the brand that we're trying to build is focused on My Health at EU. Now, keep in mind that currently, and this has been going since way back since 2012, but in operations since 2019, we currently have e-prescription and e-dispensation and patient summary. E-prescription and dispensation, they speak with themselves. That means that we are having electronic prescriptions and electronic dispensations, proof that the actual prescription was delivered, and we have patient summary, which is usually a summary of aggregated health data from different sources. So a lot's happening over there. And as of right now, we're looking at 270 country pairs, and when the EHDS will come in, this needs to go up to 800 country pairs. So quite a lot of work ahead of us. But I have something for you to remember, and today I'll be talking to you about 942 CBIT. So if you don't remember anything, remember those numbers and letters. The first, keep in mind that the European Health Data Space is 9 chapters, with a couple of them dedicated to both primary use and even others to secondary use, as you'll be seeing later. Keep in mind that the European health data space won't work on its own. It will most probably work very closely with 4 main pieces of regulation. And that is the Data Act, the Data Governance Act, and also the AI Act. So when you think about EHDS, don't think just about the European health data space, but also think about these different laws. And also keep in mind as well that there will be the NIS, Network Information Systems Directive. So a lot happening over there as well. Now, when we look at both, we are realizing that as this evolves further, we're looking at the development of 2 main infrastructures. One of them being MyHealth.eu, which I'm talking about right now, and HealthData.eu. But the MyHealth.eu will be really and truly focused on delivering these main pieces of health data. That is patient summaries, prescription and dispensation, medical images and image reports, laboratory results, discharge reports, and even original clinical documents. And original clinical documents actually is one of the forefront documents which is coming out there as well. Keep in mind that a lot of this needs to be coordinated by a designated digital health authority. So when you think about this, it is really very, very important that we create a reference point. Now, as part of our work within the Communication Task Force, where we have more than 10 countries actively contributing to this task force, we're seeing 4 main teams developing. We're seeing a big need to collaborate for connection. That means not just speaking externally, but also strengthening our internal communications. We have a lot of work being done internally, externally, but internally, we need to continue to get better and better and better to be able to deal with all the intricacies of the operations of MyHealth.eu as we go further. Secondly, we need to look at building capacity and community. So capacity internally within the national contact points of EHDS, but also within our communities, so that there is a full understanding of what the MyHealth.eu means. And even more than ever, this communication, we need to make sure that no one is left behind, and that is through inclusive equity promotion. And as we start building this, what we're doing, we're also developing the necessary infrastructure, service management, knowledge management, to even enable this and ensure that there's literally, access for MyHealth.eu for all EU citizens. And last but not least, we're also working to make sure that all possible technology is made use of, even for communication. So there are a lot of opportunities that are actually coming ahead of us, even with the use of generative AI, with the use of existing digital marketing platforms that are still underutilized in many different ways. So a lot of opportunities ahead of us. And with that in mind, I invite you to reach out to me. Here you can see my personal email, and I really look forward to see other insights and other reflections. Back to you, Nienke.
Thank you so much, Stefan, for this very nice overview and introduction to the European Health Data Space Regulation. I think this is a very good start. The European Health Data Space is here for everybody, and we should make sure that people are aware of this. So actually to build capacity and community, I think that aspect is very important. Now I would like to ask our colleagues from the Austrian National Public Health Institute to the stage to provide an overview of the secondary use of health data.
Hi there. This is Claudia speaking from the Austrian Health Institute. Nienke, will you share my slides or shall I do it myself?
You can share from your side, Claudia. So from the Austrian Public Health Institute, we have Dr. Claudia Habel. She's actually the director of International Affairs and Subsidiaries, and also a member of the executive board of the Health Institutes. We see the slides now. Claudia, your camera is not working though. We cannot see you yet.
Okay. That's a pity. I think I cannot change for the. That's a pity. Okay, I think we have to live with that for the moment. I don't know what happened. It just was working. I'm so very sorry.
That's okay. I think I showed a very nice picture of you in my opening slides, so I think everybody knows what you're.
Okay, so you see the starting building trust. It's the topic we have.
Exactly. We see the presentation. Please go ahead.
Thank you so much. You know, we have a lot of challenges, I think, at our hands. It's data availability, you know, we need legal grounds for processing, accessibility questions, data quality, the data linkages, timeliness and responsive of all the data. And there was always complaint that there is no good information in Europe, or researchers are also, you know, there's a competition among in research, you know, commercial research, but also in public research. So not everybody had the same access to data. And so we think with the data space for secondary use, this could be overcome. I think this is one of the main ideas behind everything. So it's important because for the many purposes we need it, you know, it's not only the obvious, you know, development of new medicines, or, you know, finding new genes or something, but it's also for educational purposes necessary, for all type of disease surveillance purposes, for the quality measurement across countries, and even for forensic purposes, you know. So I think the use cases are really magnified, yeah, what we can think of. So this is a great future for all the researchers in Europe. There is also a lot of new things, you know, a lot is going on in parallel. There's new data collection points. There's also the Internet of Medical Things. We have cheaper and faster omics data than ever. All the countries' healthcare systems are exploring how to, you know, digitalize it more. In my country, we even have now a political decision saying treatments, digital, prevailing ambulatory care, prevailing intramural care. So it's really a political commitment also. We have all to handle how artificial intelligence will help us or hamper us. We don't know yet. For somebody said, studying for having a doctor of X-ray in future, it's perhaps a waste of time because AI will do most of the job. So we have more data, but also more diverse data. And in the end, still, I think that the data space is let's say, a big challenge. That's true, but it's also a big chance that we all have to take, and we have to help together to make it happen. So which data do we want? It's just, I know I have only 5 minutes. It's the slides also for you to have a look into. It's an overview, what's all in. It's really amazing, and we have to focus on specific points. I think in some countries are more advanced. We have to be aware of that. Others have now the chance to break even, can I say so. Finally, where are we already? Stefan mentioned some of the data acts already. For the health data space, now the regulation is approved, but publication will be only next year. I hope we are all aware of that because of the ongoing translations. And for all of you who have a word in that, please try to have a careful, or let's comment at least internally in your countries about the language issues. Here in Austria, we identified already a couple of points where we think the translation from English into German could be crucial, how it can be implemented and in practice lived. So please have a look into this matter. It sounds simple, but it can cause a lot of efforts. I give you a small example. The regulation says fees, you know, that the bodies can ask for fees, but it depends how it's translated. In my country, it's very important it's translated in the correct word. Otherwise, it could be seen as a sort of additional tax, just to give an example. Of course, we have to look at the categories of health data, Article 33, Article 34 about the legitimate use, and what I like much on the new version, the ethic topics. It was, you know, we are a public health institute, so this is really important. And in our country, you know, let's say not everybody is a big fan of sharing this cross-country data. Even we have no good tradition of sharing it nationally. So ethics appear more, and I like especially there is a new various which is especially addressing this topic. And I know there was a really good, let's say, bridge between France and Germany to make this happen, that this topic is now there. Also others, of course, helped, because this will help us. It's all about trust. It's not so much about techniques. And this is what also I want to come. I only have little time now, I think, Nienke, and I think some of you have seen it. which bodies do we talk? The health data access bodies. I'm only talking about the secondary use here, that we have coordinating bodies. If there's more than one access body, we need national contact points for this use. So there's a couple of bodies who have to be implemented in all the countries. And if we do it well, we can work together. There's already some joint actions in plan, the TEDAS 2, for those of you who have heard about it. And we will follow up on this point as well, of being have capacity building among ourselves as potential such body, I may say. Now for discussion, and if we have time later, I think it's very important to have the opt-out in our minds. We think in the current version of the regulation, the role of data altruism could be less important as it was originally. We have to talk a lot about the obligations of health data access bodies toward natural persons, this new Article 35E. We need to ensure public value for all of this. Otherwise, people will challenge us in some time saying we build up, I don't know, 100 millions of euros which are invested in all the countries together. For what? If then researchers complain again in 10 years, they have no access to information, I would not be the one who have signed all these budgets. Yeah? And it's not only, I think, informing decision makers or patients, I think it's rather convincing them. And here also the role of health data access bodies, despite they might be a bit seen technically, I think they have a very, very big role in building up this trust. And with that, I can only conclude that we need really a well citizen information portal. This could have layers for journalists, could have a special enclosed layer, perhaps for policymakers, but it has to be seen not only as a technical exercise, but really as a policy exercise. Thank you.
Thank you so much, Claudia, for this nice overview, and also that you're showing the extra additions to the text that was proposed already 2 years ago and the text that is finally adopted. I think the Austrian National Public Health Institute will also lead one of the work packages in this TEDAS that you've mentioned. This is a joint action towards the European health data space, which will also focus on the implementing acts of this regulation. Now, let me share my screen because I would like to show you the next part of our webinar, which are short pitches that will tell you a little bit about initiatives that mapped trust and also initiatives that will foster trust. So first up, we have my colleague actually in the Institute, Louise, who will talk about a citizen consultation in secondary use of health data. Then I have my colleague from Italy, working together with Fidelia a lot in other projects such as Quantum, about sharing attitudes for primary and both secondary use. Our colleague from ETL, who is leading a work package in the ECSHARE project, all about sharing health data with the click of a button. And then finally, we have Isabella Bos, a senior scientist working at NIVEL, about trust of citizens and healthcare professionals in the data exchange and reuse. So first on stage, Louisa, you will be, it will be possible for you to share your screen from your side. You're still muted.
Can you hear me now?
Yes, we can hear you.
Perfect. And can you see my slides?
We can also see your slides.
Great. Hello, everyone. My name is Louise Mathieu. I work, as Nienke said, at Sciensano within the Cancer Center, and I'm involved in a team that is dedicated to ethics and public engagement. And today I'm going to present you the LC data consultation. So the LC data consultation was set up within the joint action TEDAS, who counted with a work package solely on citizens. We conducted that project together with the French Health Data Hub and with the NHS Confederation from the UK, and it was co-funded and run together with the Belgium project AHEAD. So the goal of this consultation was triple. We first wanted to raise awareness among citizens and patients about the secondary use of health data. We wanted to gather their perspective on the secondary use of health data, as well as how they would like to be involved in this future framework. And our final deliverable was to elaborate recommendations for the European Commission to inform them about citizens' values and involvement regarding the secondary use of health data. The project was run between February 21 and February 23, as you can see here in the timeline. And to give you some numbers, we reached near to 6,000 contributions and more than 39,000 visitors visited the website. So thank you for the opportunity today to talk about trust, because this was a very important concept to us. So here I'm just going to try to explain briefly how trust, the concept of trust, is linked to the health data consultation. So I think it is the premise here and for TEDAS and within the EHDS that citizens play an essential role in secondary use of health data, and that there is a need in the end to count on public trust. And in our vision, within our team, trust comes with strings attached. We need to respect citizens' views and values in order to foster such trust. And in essence, the best way to do this is to treat them as actual partners within this framework. But what the consultation did, I think, in my opinion, is before fostering trust itself, is to identify the factors that influence and constitute public trust and to understand what is to be enhanced exactly. Otherwise, we might not completely understand the public concerns, and we at the risk of presuming or assuming what they think about the way health data should be used and how it should be used, and at the end of shadowboxing their perspective. So what constituted public trust as per the LC data contributors? Well, clearly from the beginning, what we understood is that if we want to understand citizens' perspective on the secondary use of health data, we need to understand their perspective on data per se. And in the consultation for citizens, health data were a piece of them. It's a piece of me, it's a piece of my identity, including in the case of secondary use. So any user who's engaged in the secondary use of health data is actually engaged in this data relationship and with the people behind it. Another key message from the consultation is that citizens identify data as power, so power to do good and power also to be harmful. So this is a takeaway, and the perspective then of citizens on the secondary use of health data, we labeled it the conditional beneficence, which means that citizens want to trust the secondary use of health data. They believe in the good and the benefits it can bring, but this trust is not blind, and they need to be sure that this beneficence will not be taken advantage of. And so in the end, this trust is conditional. So whatever forms or no forms of engagement or information they want, the key thing is that data should be used in a way that they support. Here, what you can see is the visual visual we built from the descriptive analysis of the contributions. So before we organized workshop with experts and we established the recommendations, and we built it in a way that could inform a framework for the EHDS as per these contributors. And so very briefly, what this visual says about this concept of conditional beneficence and about trust and how you should read it, here are some key messages. Citizens see themselves at the beginning and at the end of the secondary use, which means that data should be used for their ends, so for our ends as a society, and not solely for someone else's goal and objectives. All the elements you can see in these visuals are basically the elements citizens thought should be paid attention to. They constitute, this is all the parameters and conditions that constitute their trust in a framework for the EHDS. And one thing that needs to be understood and why there is an infinity symbol is because this overall framework is dynamic and can change depending on the conditions in place. To give you an example, for example, if a commercial actor would be involved in the secondary use of health data, citizens would like guarantees that benefits would actually be shared with society and for the common good, or that there would be more security oversight, for example. A way of reading this visual as well is from left to right and right to left. So from left to right, here we describe how citizens can feed the framework and how they can be engaged in the framework of the EHDS. And from right to left, how the framework can respect their values and can foster trust. Two conclusions regarding trust here is that trust is variable. It is a spectrum which can vary depending on the parameters of the framework, and that it is non-binary. It needs to be earned, it needs to be fostered as in any trust relationship. So engagement should not be treated as a one-step process, but as an ongoing process. Otherwise, citizens' views can deteriorate. If you want more information, there is the link below to the full report. And all this allowed us to build 12 final recommendations for the European Commission in the context of the EHDS proposal back then, so February 2023. It is, according to us, a first step to inform the European Commission on citizens' values and to co-construct a suitable ethical, legal and societal framework. And since we are at the beginning of the development and implementation of the EHDS, both at European and national level, there is a huge opportunity for such co-construction. Thank you very much for your attention, and back to you, Nienke.
Thank you so much, Louise, for presenting this nice overview and actually the big effort that you did in the citizen consultation. I think it's nice that you mentioned that for us is an ongoing process. It needs to be fostered. So I think it's good that there's now much more attention for it, but let's hope that we keep the attention and we keep our eye on the ball when it comes to fostering these trust initiatives. Thank you so much, Louise, for your presentation. Next on the stage is my colleague from Rome, Fidelia. Fidelia, she is an assistant professor in hygiene and public health in the University of Rome and also a digital health expert. Fidelia, you can share the screen from your sides. Yes,
thank you, Nienke.
See them coming up. Thank you so much, and the floor is yours.
Thank you, Nienke. Good afternoon, everybody. I'm going to share with you the results of our last systematic review exactly on health data sharing attitudes, which is perfectly in line with the results which Louise highlighted just a few minutes ago. What we found with this systematic review, and especially what's the added value of this literature search. We have three main elements to highlight. The first one is that this review, which was well published because it was published on eClinical Medicine, which is part of the Lancet family. The first one is to increase the knowledge base regarding the studies on health data sharing, and this is the first review summarizing all findings on willingness to share health data and underlying motivations and concerns and predictors. But also this review is contributing to give evidence from 2,100 screened articles. At the end, we selected 116 articles, which give us inputs on both primary and secondary purposes of sharing data, and we grouped the studies and the attitude of sharing data into four main categories related to types of data. The first one is related to personal health data, the second is person-generated health data, and then biobank data and genomic data, which contributed to give us differences in sharing data also according to the types of data. And also this is a very accessible paper because it was published as an open access paper. But what are the main findings? As expected, people are generally very willing to share health data for primary purposes, differently from secondary purposes. In fact, people are more open to share their data for means of receiving care. But most importantly, although a great number of studies concluded high support for some secondary uses, especially for non-commercial research, the attitudes of people vary greatly depending on the type of data recipients. As you can see here, in particular, health professionals and healthcare providers are perceived by people as the most reliable recipients. And non-profit organizations and public institutions received higher support than profit and private companies. So what are the conclusions based on these literature search and the published paper currently available? That first of all, people share the same concerns, mostly on privacy and security, regardless of data type. The second one is that people's attitudes towards data sharing increase when they perceive that health data sharing will help the improvement of healthcare the advancement of health knowledge, and the discovery of disease treatments, so for benefits. The third point is related to the awareness of people and the idea that overcoming barriers, addressing concerns, and spreading awareness about the data sharing practices lead to a more active data sharing society supporting the secondary use in all the purposes, medical research, health policies, public health purposes, personalized healthcare. It depends on the case. And we found in this regard that an interesting study, which is the only one intervention study involving Finnish undergraduate students, which demonstrates that the rate of supporting students increased significantly after receiving education about sharing the genomic data for secondary purposes. So at the end, what we can conclude that people need transparency and reliable privacy and security protection tools to be more open towards data sharing. Thank you very much for your attention. Nienke, over to you.
Thank you so much, Fidelia, for this very nice overview and actually this amazing publication. So yeah, if you could post again the link in the chat, because she just published this in the Lancet Clinical Medicine. So I think it's very nice for people to make sure that they read the paper. I think it's nice to see that also Louisa mentioned that there's a great willingness to share health data. I think this is both for primary use and also even for secondary use. So I think this is a very hopeful message at the moment. So thank you so much, Fidelia, for your contribution.
Thank you, Nienke.
Then I would like now to welcome to the stage Luc Nicolas. He is will be presenting the EUPHA project. He actually is an ICT for health expert at ETL, but is also leading a work package on public health in this EUPHA project, which is an Horizon-funded project that's just started at the beginning of this year. Yeah, I see you at the stage, Luc. You can share the slides from your end. Yes, we see them. Thank you so much, and the floor is yours.
Yes. Good morning, or good afternoon already, everybody. So I would like just here to bring to your attention a project which has really trying to project ourselves into not the old use cases, but into the new paradigm that the EHDS might help to create the conditions for. So in the EHDS, there are three overarching concepts. The first, the question of accessibility to data, where the patient for the first time is established as the key player, and he needs to take control. So there is a clear link between access and control. Why? Because we believe that giving the patient to be in control will facilitate the exchange of data. And as we will see in this project, we connect primary and secondary use in a more closely way with the patient at the center. The second concept is interoperability, where here the idea is that all people who develop systems, be them public or private, must be globally accountable for the results. So they can't develop any more solutions with only their own finality in mind. So they need to interact for mutually beneficial goals. And finally, the question of data reuse. We need to create data to create data in such a way that we can take the maximum benefits out of it for research, innovation, policymaking, regulatory, and so on. So if I had to just come back 1 second on this idea of access, I would say that just opening the door to the citizen, giving him the view that on all the data is nice, of course, but this is not what will make the difference. What we need is that the patient have access to computable data that they can really activate and thus create the conditions for new things, precision medicine, personalized medicines, but also contributing to new societal value. And this with many more colors than the blue that you can see through the open window from an pure accessibility point of view. If we look into interoperability, that's a bit the same. We have a long-standing premise, and there have been a number of interesting things being done. We know that it's a complex aspect which needs to be tackled at different levels. But actually, this promise has not completely materialized, although we have been investing a lot of time, energy, and resources in trying to have systems communicating with each other. But let's be clear, our world is still full of silos for many different reasons in the private and in the public sector. What we want to do in eXhare is basically to go beyond what the regulation is doing, and they do it for very good reasons. We have two different tasks, primary use and secondary use. But we really believe that we also need to consider, of course, the two together as a dynamic ecosystem with the patient at the center. So that when data are produced in the primary use, they really have a capacity to feed secondary use purpose in the same time. So in order to do that, we believe that we need to align the incentives so that everybody is really motivated to adapt their systems and their habits and the organizations. We believe that reducing the administrative burden for clinicians will be an important incentive so that they don't have to duplicate data anymore. And we believe that we indeed need to give a new role to the patient in order to activate the data and create the condition for a dynamic ecosystem where new use cases can be developed. So in eXhare, the vision, this is that everybody can share the health data with a click of a button. And there are two concepts basically for this dynamic ecosystem. The industry partners who will comply with the new specifications, which are not yet fully defined, but already pretty much advanced. There are already implementation guidelines and quite a number of implementation being tested in a number of member states. They will be able just to say, we are EHR, the EHR X5 compliance, thanks to an industry label that we want to create. And at the same time, the systems which can interact with the patient, so the patient portal, the patient personal health record app, for example, thanks to a click of a button, we receive the structured data from different partners, healthcare partners, and we'll be able to share them for different kind of purposes. So with those two concepts, we believe we have the condition, together with a hub, that we will help to define and distribute the specifications and all the support needed to understand and apply those specifications. We have the conditions for a dynamic ecosystem. So if we look what is specific here in the project is that we're not only looking at the data portability under GDPR, which is mainly for primary use, but we're also considering all the data set in Europe which already in use, or data sets which will be created in the future, but that are already in mind for public health aspect, which could be fed totally or partially with the EHR X file, which are now which will be fully defined in the implementation acts. And that's the same for clinical research, basically. And we also make a link between public health and clinical research in this. We do it thus, as you can see, thanks to the creation of this hub and to a number of services which will link use cases, specifications, and implementation, where we'll define this, and with a close link with the standards. So that's also a new way to bring the regulatory domain and the industry-driven initiatives together in the same kind of environment, working just on the workforce, on the health system aspect, on the citizen empowerment and the digital health market, finally, enhancement. So I don't repeat that has been done. You know the 6 categories of data which have been selected by the regulation. We already believe that with this, we have a lot of possibility. They have already been prepared by another project called ExpandEH. We will further enhance that next year, and we'll create then the hub, and hopefully also an alliance, which will bring together, as I said, not only industry partners, but also regulator partners, so that this co-creation aspect can be fully taken into account. We have new use cases here, that's 2, which have already been selected, but there are much more. And as you can see, for example, that's an example of the international patient summary, where we have been trying to match this with what could be used in the research domain and in the public health domain. So trying to create an extension or trying to see which kind of specifications need to be added to be fully useful for a number of priority use cases. So in public and population health, we believe that thanks to those EHRS files, we have the possibility to create the conditions for a better only one strategy for the registries already in operation. We will contribute to create a new real-time monitoring dashboard opportunity. So basically just trying to analyze data on the flow, and we know which one will be available because they will be in the right format. We also have the possibility to have new types of data analyzed thanks to the participation of the patient itself, and the capacity to involve new kind of different actors than the ones which were used before. And finally, new possibilities of collaboration, especially across border. There's the key interface for the trusted parties, and that's another element. So the X-ray yellow button that the patient will be able to activate will interact with trusted people, which will respect a number of conditions, legal conditions, of course, but also will be legitimate in their purposes. So, for example, to work on precision medicine, on patient discovery, on supporting innovation, on population health in particular, when trying to address the needs of specific populations, or to try to see how the accessibility to services can be better served. We can develop PHR with much more advanced functionalities to support the patient, and as I said, the key accelerator for new use cases. So that's why we believe that this button will definitely allow health system to easily solve cross-border data interoperability issues. Thanks to this hub that we will be creating, and we will be also associating all the other actors to an alliance that will foster the rules for the functioning of this hub. So with this, I would like to close, and we'll be most happy to include any of you who are interested in this project in our further workshops. Thank you.
Thank you so much, Luc, for providing a very nice insight in the workings of the X-Share project. Of course, maybe you could post in the chat where people can reach you, because I think there might be some people who are very interested in the work that you are doing, and Sciensano also, because we are involved in, of course, in your work package. I think it's a very nice way of showing something that can actually foster trust, as it being an ongoing process, as we established before. This can really help put people more in control, perhaps, of their data, as of course control might be part of this complex topic that is trust. So thank you so much for your contribution, Luc. Last but not least, I would like to welcome to the stage Isabelle Bos. Isabelle is a senior researcher, healthcare data and health systems at Nivel, and she will be talking to us about trust in of citizens and healthcare professionals, also in health data exchange and secondary use of health data. Thank you so much for joining us, Isabella, and the floor is yours. You're still muted.
Can you hear me now?
Yes, we can, and we can see your screen. Please go ahead.
Great. Thank you. Okay, well, thank you for having me, and great to hear all the other talks about this, well, interesting and important topic of trust in healthcare data sharing. I would like to share some of the results of a study we recently conducted regarding trust in health data sharing, which was financed by the Dutch Ministry of Health, Welfare and Sports. And we also already published a report regarding this study, but unfortunately it is in Dutch. But I think you can all use Google Translate or ChatGPT to look into it. If you want, I can post a link in the chat later on. Let's see how I can go to my... So, as already mentioned, trust is a complex concept, which also makes it quite difficult to conduct research into trust. But we did do this, and we looked at the perspective of trust from citizens and patients and healthcare professionals, because both groups are really important to have this trust in data sharing for primary and secondary use. So we looked at many different perspectives of trust in health data sharing. And as time is limited in this presentation, I will first go into the results of what we found, and then I will go into how we investigated this. So this slide actually shows an overview of the results that we found of what we call the building blocks of trust in data sharing. So we have on the left side the primary use, and on the right the secondary use. These are actually the considerations that are important, or the factors that are important for trust of citizens, patients, and healthcare professionals. I'm not going to go into them all. I think most of them are, well, the usual suspects. For instance, for proportionality, it is important to mention that for citizens and patients, it's also the communication regarding the proportionality. So it's that they don't know that only relevant data is being used, which is important for trust. And for healthcare professionals, data quality is a really important aspect. And lots of things are important. They are context dependent. So it is difficult to say that one direction will enhance trust, because in another situation, citizens and patients might, and healthcare professionals as well, might reconsider their opinions. But if you see this overview, it looks quite simple to enhance trust and to create a safe environment for data sharing. But I think it is not as simple as it seems, because trust is complex, and primary and secondary use of health data are complex concepts as well. And this often leads to misunderstandings. And also, as another presenter also already mentioned, we noticed that trust is dynamic and it changes during conversations or during the day. Concepts like anonymization and de-identification are really important, but we often found that it is too complex to really understand what is going on. And then often the response is that it leads to less trust. So this is something that we should avoid, of course, but it is important to realize this. Our study was mainly focused on the national perspective, so the Dutch perspective, data sharing in the Netherlands. But we also did a short discussion regarding the European perspective. And we found that it's not that the opinions and considerations within a national level are easily transferable to the European level. So this would deserve additional attention from other studies to really dive into the European perspective. Although often the considerations are that first things should be well regulated on a national level and then go to the European level. So that's maybe an important consideration. So how did we actually do this? Very quickly, I will tell you. We did a literature scan, so not like a meta review that was already presented. It was a quick literature scan to look what has already been investigated. And we organized a citizens platform, which is an interactive meeting with a group of citizens to discuss complex healthcare issues. And this platform was totally focused on trust and health data sharing. And we also did a healthcare professionals platform. And during these platforms, participants get presentations from experts, but they also do group assignments to really understand and form their opinion and their considerations. And I would just quickly like to show you one of the assignments that they did is we used this dashboard, which we created, which was based on our literature scan and was based on a discrete choice experiment kind of method. So we built what we call switches to investigate the considerations that participants might have under which circumstances they would like to share their health data. And we used case studies to investigate this on a more deeper level. But it was not to, it was actually to have a conversation about this and to have discussions, not to collect hard data. So our conclusions were that citizens and healthcare professionals, they understand and they underline the importance of health data use, but it is difficult and opinions are polarized, especially when it comes to secondary health data use. So as already mentioned, transparency is important, and that it is important that when choices are made in this about health data sharing, that it is explainable why these choices are made. And several recommendations we formalized regarding our study. So this was it for now, and these are all the colleagues.
Thank you so much, Isabelle, for presenting your research that you've done into this topic. Very interesting, especially this to really using this discrete choice experiments to really find out more, to really quantify the way that you can the trust in data sharing. So that is very, very interesting. There is a question actually for you in the chat, so let's stay on stage for a bit.
Sure.
So a question said, can you indicate whether the use and availability of personal health data environments had any effect on the views represented?
Yeah, well, in the literature scan, we did find a lot regarding these environments. In our platforms, we did not really discuss this because not all participants were aware of this, so they did not know that it existed. But I do think it would be a nice method to actually inform. There was also a switch that we used on our dashboard is, do you want to stay informed regarding your health data sharing? And the opinions were actually quite polarized. So some of them really wanted to stay informed and others were, no, I don't care what they do with my data. So I think it's a mixed, it's not to say that one way or the other works best.
Thank you for your comments, Isabella. Let me see if there are any more questions in the chat. We're also almost running towards the end of the webinar. I see indeed there is not much of a question, but also a comment. I think it's not only important, of course, to have the trust of healthcare professionals. I think it's a general comment, but also to extend it to the data holders in general. And I think this is indeed a very important point. I think in the European health data space, there are more actors than citizens and patients we've been focusing on. So indeed, it's also very important to focus on the data holders as well. All right, I think there are no more questions at the moment. Let me see. Yes, there's a question. Could you share the link to the report? A question from Andrea. I think it's to you, Isabella, and I think I also might be very interesting. So if you could input or you put the link into the chat, that would be
I just
great.
did.
Ah, fantastic. Okay. All right, then we are now at the end of the session. In this session, we try to provide you with a quick overview of what the European Health Data Space is, and provide you some insights in the importance of trust in the European Health Data Space, not only of citizens, but also of health professionals, patients, and of course, other stakeholders in data sharing in this new space. Maybe some quick takeaways I noted down. There are much more, so I will I made a recording of this, which will be sent to you as well, so you can also take a look later and see if I'm correct in this very short summary. I think there's a great willingness to share health data, so there is some trust that we can already build on, both for primary use and for secondary use, but building capacity in a community is very important, as trust is a very complex process or topic. It's a result of data type. There's also data quality, security, access, control, and of course understanding, linking back to the capacity building, and also the trust in the individual stakeholders in the European Health Data Space itself. Trust as an ongoing process was mentioned. Trust is context dependent. And I think it's interesting that there was a mention of the citizen platform by Isabella from NIVO, and I think Claudia also mentioned it already in the first part of this seminar, that creating such a citizen platform is very important as a first step in building trust. And with this, I would like to thank all the speakers for their pitches. I would like to thank my co-organizers, the Austrian National Public Health Institute, and of course the EUPHA sections on public health monitoring, reporting, and digital health for their help in setting up this webinar. And of course EUPHA for organizing yet another very exciting public health week. Make sure to tune in at 3 o'clock for our next webinar on the regulation of AI in health in Europe, which is also quite interesting, and we have a quite great panel for you lined up there. And I also would like to thank the audience for their time and their attention. And then I would really like and would hope to meet you all in person in Lisbon during the European Public Health Conference in November. And I wish you all a great afternoon. Thank you so much.